Hi, good morning, everyone. Welcome to our 141st session of CMAAO International Weekly Meeting. We are live every alternate Saturdays, and we bring a platform for a discussion for all the doctors on this forum. Today, we have Dr. Avinash Parmar. He is MBBS, MS General Surgeon, FMAC, Consultant General and Laparoscopic Surgeon at PD Hinduja Hospital and Medical Research Center. Today, he is discussing about non-obstetric surgery emergencies. Sir, over to you.
Okay. Hi, good morning. Thank you so much for your kind words. And the topic, I was a bit in dilemma what to discuss, what was this being a first CMAAO meeting. So I just thought, being a surgeon, let me just pick up the topic which can be useful for every one of us, the gynecologist or the surgeon. So now to begin with, I would definitely start a quote with Mr. Winston Churchill. Sorry for the delay again. So a famous quote by Winston Churchill that success is not final, failure is not fatal, but it's a courage to continue that counts. So here, with so much of glitches in the earlier session, not getting connected, yes, success was not the way, but failure, it was not fatal. And here is the courage that is making it count. So to begin with, yes, the pregnancy can be complicated with different surgical emergencies, which may potentially endanger the mother as well as the kid, the fetus. Diagnosis and treatment both carry dilemma, followed by a debate on the safest surgical approach during the pregnancy, which continues. Here, the appropriate early intervention is essential to decrease the morbidity as well as the mortality. Now, non-obstetric pathologies during the pregnancy can be seen in 1 to 2% of the cases. During the pregnancy, 0.2 to 1.0% of the women require general surgery for non-obstetric problems. Here, the acute abdomen develops during 1 in 500 to 635 pregnancies, out of which the gastrointestinal disorder account for 0.5 to 1% of the presentations, which requires a surgery during the pregnancy. Now, little bit basic on the anatomical and physiological changes which occur during the pregnancy. That usually affect the presentation of the abdominal pain, which can be acute or chronic or subacute sort of pictures. Heartburn and constipation is very frequent because of the decreased gastric motility. The gravid uterus, approximate of which is around 12 weeks of gestational age, that compresses the abdominal organs, displaces the underlying and surrounding viscera. The expanding uterus make it difficult to localize the pain and can mask or delay the emergence of peritoneal signs. The increased laxity of the anterior abdominal wall can also further delay the peritoneal signs during the pregnancy. Now here there are the hormones like estrogen, progesterone, which carries a major impact over the anatomical and physiological changes in the pregnancy, which in turn affects the GI tract and most of the other things also. Mainly the progesterone, it prepares body for a pregnancy by relaxing the smooth muscles of the body, which also affects the gastrointestinal tract. The progesterone relaxes the lower esophageal sphincter and decreases the gastric motility, which I mentioned earlier, which increases the frequency of heartburn, GI, and nausea during the pregnancy. Progesterone also causes bile stasis, increases the incidence of cholelithiasis, and which eventually results in cholecystitis during the pregnancy. Additionally, elevated levels of estrogen increases the concentration of the bile, which also increases the formation of cholelithiasis and risk of acute cholecystitis. So estrogen as well as progesterone both plays a very important role in bile stasis which results in formation of the cholelithiasis and eventually the cholecystitis. Now, what are the most frequent indications for surgery during pregnancy? There are so many things, like, and I can enlist, but I have selected a very common in terms of which requires an emergency surgery during the pregnancy, acute appendicitis and cholecystitis, apart from the ovarian disorders and bowel obstruction, as well as for trauma and oncological conditions. Other than this, definitely there are infected cysts, carbuncles, hemorrhoids, which are external thrombose, grade 4 coming up for surgery. These are the other indications for surgeries which eventually takes during the pregnancy as an emergency. Managing such scenarios can be equally challenging for both the obstetrician as well as the general surgeons. Now, here I'm dividing this indications into non-gynecological and non-obstetric, non-gynecological and non-obstetric causes. Non-gynecological and non-obstetric causes would be acute appendicitis, which is 1 in 1,000, symptomatic cholelithiasis. Symptomatic, not the silent gallstone, it's a symptomatic cholelithiasis causing cholecystitis, 1 in 2,000 pregnancy. Intestinal obstruction, 1 in 1,500 pregnancy. Cholangitis, 1 in 1,200 pregnancies. Acute pancreatitis, 3 in 10,000 pregnancies. It's there, but it's very rare. And peptic ulcer perforation, because the PPIs has gone down very, very, very low. Now, gynecological and non-obstetric causes. Here, the twisted or ruptured ovarian cyst, 5 in 10,000 pregnancies, and torsion of the pedunculated subserosal fibroid, which is again very rare. Obstetric causes, acute ectopic pregnancy, that is 19.7 in 1,000 pregnancies. Ruptured uterus, again spontaneous, 1 in 8,000 to 1 in 15,000 deliveries. Ruptured uterus with risk factors, 1 in 1,633 deliveries. So these are the causes. Now, here I'm more focusing on the abdominal pain during the pregnancy. These are the differential diagnoses of gastrointestinal tract, genitourinary tract, gynec causes, and the vascular causes. The gastrointestinal tract includes appendicitis, cholecystitis, hepatitis, sometimes yes, omental infarction, Crohn's disease, ulcerative colitis, diverticulitis, cholecystitis, inguinal hernia. Again, the hernias definitely yes. Hernia, strangulated incarceration, and obstruction, definitely yes. This could be one of the differential diagnoses. Bowel obstruction, pancreatitis, gastric ulcer, duodenal ulcer, and peptic ulcer. And under genitourinary tract, urolithiasis, pyelonephritis, and urinary tract infection. Gynecological, again, I had mentioned in the list, adnexial torsion, ruptured ovarian cyst, salpingitis, and TOA. Vascular causes for the differential diagnosis, yes, MI, aortic aneurysm, ruptured spleen, and retroperitoneal hematoma. Now, yes, being a general surgeon, yeah, appendicitis is one of the most common problem encountered within pregnancy. Incidence of appendicitis is same as a pregnant and non-pregnant woman. Appendicitis occur, as I mentioned earlier, 1 of every 1,500 pregnancies. Most common, it's usually found in second trimester of the pregnancy. The perforated appendix increases fetal morbidity as well as mortality, which are as high as 20 to 30% with perforation and as low as 0 to 1.5% in uncomplicated appendicitis. Now, symptoms wise, yes, in classic scenario, periumbilical pain radiating to the right lower quadrant. Following the onset of pain, anorexia, nausea, vomiting, fever may also develop. And again, the anorexia, nausea, vomiting, yes, the pregnancy, early pregnancy symptoms also go, but here again, the differential can be done based on the lab investigations and image. Abdominal examination usually reveals the tenderness, rebound tenderness, and involuntary guarding, classically over the McBurney's point. Now, diffuse peritonitis or abdominal wall rigidity suggestive of appendicular perforation. When the appendix is in retrocecal region, pain is usually described dull rather than localized and sharp, which is elicited more likely to be by rectal or vaginal examination rather than abdominal examination. Accordingly, the pelvic appendix may cause tenderness below the McBurney's point Again, irritation of ureter giving rise to urinary frequency, dysuria, tenesmus, and diarrhea. These are the presentation of appendicitis. Now, the pregnant people are less likely to have a classical presentation than a non-pregnant people, especially in the late pregnancy, because of the gravid uterus stretching up. However, the location of appendix migrates few centimeters above, that is cephalad, towards the liver with enlarging uterus. So in third trimester, the pain may localize to mid or even on the upper right side of the abdomen, right hypochondriac region. The McBurney's point tenderness may be less prominent because the gravid uterus lifts and stretches the anterior abdominal wall. Since the direct contact between the area of inflammation and parietal perineum is impeded, there is a less rebound tenderness or guarding. The gravid uterus may also inhibit the contact between the omentum and inflamed appendix. So these are the variants of presentation of an appendicitis. Now, 80% of non-pregnant patients with this appendicitis may have a preoperative leukocytosis, quite some more than 10,000. We have seen a patient, pregnant female with counts of 29 to 30, reaching maximum 30,000 with the left shift. However, the mild leukocytosis can be normal finding in a pregnant individuals. The TLC may be as high as 16,900 in the third trimester, or rising high as 29,000 during the labor. The microscopic hematuria and pyuria may also occur when the inflamed appendix is close to the bladder or the ureter. Mild elevations in serum bilirubin have been described as a marker of an appendicular perforation, sensitivities being about 70%, specificity of about 86%. Elevated CRP occurs in appendicitis, but it's sort of a non-specific sign of inflammation. Now, diagnose. According to the SAGES criteria, the ultrasound imaging during the pregnancy is safe, effective in identifying the etiology of the acute abdominal pain in patients and should be the initial imaging test of the choice. Very strong evidence with this. Now, MRI without the use of IV gadolinium can be performed at any stage of the pregnancy. MRI is preferred over the CT scan for diagnosis of non-obstetric abdominal pain in gravid patients. Again, yes. Now, CT scan may be used in emergency situations during the pregnancy. It should not be the initial imaging test of the choice. First, ultrasound, second, MRI, and third, a CT. Unless the situation is warranted, then take a look for the CT. Now, here, these are the few images, normal versus abnormal imaging in USG, turgid appendix, increased vascularity, periappendicular fat stranding, periappendicular fluid collection, MRI imaging, and CT imaging, which I have put it on my slide. Now, management of appendicitis. Antibiotic therapy alone for the patient with appendicitis should be considered experimental, as well as available. The available data are very limited in this. The proper counseling for the possible increase in maternal morbidity should be discussed with the patient and the relatives. There was a study which included about 7,100 pregnant individuals with the non-complicated appendicitis. Medical management was associated with the increased risk of complications compared with appendectomy. In adjusted analysis, the specifically increased risk individual included the peritonitis, DVT, sepsis syndrome, and septic shock. Usually, the curative treatment for appendicitis is appendectomy. Now, could be again laparoscopy or open technique. These are two main approaches. Delaying surgical intervention for more than 24 hours after the first symptom, yes, increases the risk of perforation. No randomized trials have been performed to suggest that one technique is better than the other, the lap or open. Therefore, a choice of technique should have its basis on the patient clinical status and the preferences, the gestational age, and the surgeon's experience level. Doesn't make a difference. If you're not confident with the lap technique, do an open technique. Now, over the 2 decades, some argued that laparoscopy was contraindicated during the pregnancy due to the concerns, yes, because of the uterine injury from the trocar replacement and fetal malperfusion due to pneumoperitoneum. However, the current guidelines state that the lap appendectomy is standard of care in patients with the pregnancy as it is safe. This allows easier identification of the appendix and offers an opportunity for an evaluation of abdomen for any associated pathologic process going on. Now, when performing an open appendectomy in a pregnant patient, yes, during the open appendectomy, transverse incision is made at the maximus point or over the point of the maximum tenderness. When the diagnosis is less certain, the lower midline vertical incision can be used as it permits adequate exposure of the abdomen for diagnosis as well as the treatment of surgical conditions that mimic the appendicitis. The vertical incision can also be used for cesarean section again, if subsequently required during the obstetric indication. During the cesarean section, yes, you can definitely take out the deceased appendix. The most important thing, it is prudent to minimize the traction of the uterus and the uterine manipulation, although an association between these two maneuvers and preterm birth is unproven. So be careful with that. These are the images, whether open appendectomy size at the maximus point or size and maximum tenderness, lap appendectomy, again the port placement have been shown with that. There are the case reports, case series, and cohort studies in pregnancy suggest that a lap appendectomy can be performed successfully during all the trimester of the pregnancies with very few complications. Again, the decision to proceed based on the skill and the experience of the surgeon, as well as the clinical factors, the size of the gravid uterus. There can be some modification to the lap surgery, like a slight shift of the left lateral positioning of the patient during the second trimester. Again, venous return. Use of open entry trocar or placement of trocar under direct visualization and limiting intra-abdominal pressure less than 12 mm of mercury has to be made sure. However, the concern has been raised that laparoscopic appendectomy appears to be associated with higher rates of preterm delivery and fetal loss. There is a concern. Yeah. Now, this is just a flow chart. A patient with suspected appendicitis, USG again, which is positive for appendicitis, you can operate. A non-diagnostic or negative for USG, again, one part low clinical suspicion for appendicitis, observe. Moderate or high clinical suspicion, first trimester MRI, second or third trimester MRI or CT. MRI should be the first. Sonography definitely number one, second MRI, or third one is MRI or CT. Clinical indications for surgery like acutely inflamed, diagnosed on sonography, lab value is high, take her to the OR and get the appendix out. The second most important thing is appendicitis. After appendicitis, cholecystitis is very common. The acute gallbladder disease like cholecystitis with cholelithiasis, acute acalculous cholecystitis seem to be more common in pregnant women than in non-pregnant women. Incidence being 0.05% to 0.8%. Yes, again, as I mentioned earlier in my slides, the estrogens as a progesterone are both causing the bile stasis and resulting in gallbladder stones and eventually the cholecystitis. Progesterone leads to smooth muscle relaxation of the bile sludging, creating a good environment for the development of gallbladder stones. Now, signs and symptoms of acute cholecystitis are similar to those in non-pregnant population. Again, nausea, vomiting, fever, right upper quadrant pain. Fever may or may not be there. Lab values typically not visible because the WBCs, amylase level, and alkaline phosphatase concentration are all elevated during the normal pregnancy. Now, the diagnostic test of choice for all this patient, right, hypochondriac pain is USG, sensitivity of about 95 to 98% accuracy. Wall thickness, gallbladder wall thickness more than 3 to 5 mm, yes, positive for cholecystitis. Presence of pericholecystic fluid, presence of gallstones, and presence of Murphy's sign elicited during the sonography. If the diagnosis and surgical evaluation are delayed, the risk of complication increases. The complication may eventually lead to gallbladder perforation, peritonitis, and sepsis, and they can cause the preterm labor, contribute to fetal demise, and increase the maternal mortality rate. Surgeon may choose a conservative management in case of acute cholecystitis. Serial monitoring the patient, WBC, CRP levels going down definitely can be conservatively managed. Or cholecystectomy, which requires a surgery. The conservative management, yes, again, consists of hydration, supportive care, antibiotics with either beta-lactamase inhibitor such as ampicillin sulbactam, piperacillin tazobactam, or ticagrelor clavulanate. An alternative antibiotic regime would be again third generation cephalosporin with metronidazole. The cholecystectomy, lap cholecystectomy is proven, yes, very safe. Like a lap appendicectomy, again, the port placement over here should be above the umbilicus, depending upon the size of the gravid uterus. Here again, I'm repeating the guided trocar entry in terms of open technique or putting a trocar 12 mm or 10 mm trocar under direct vision should be tailored. Here, a flow chart for managing the gallstones in pregnancy. If asymptomatic, follow up. If patient has got biliary colic, complicated gallstones, again, laparoscopic cholecystectomy should be done. With CBD stones, ERCP, the stone should be extracted out. In an uncomplicated gallstones, if an surgery is possible, then do the surgery. If surgery is not possible, here there are two scenarios: a small cholesterol stones, again less than 5 mm and more than 5 mm. Less than 5 mm, yes, biliary sludge can be managed with the oral urodiazolic acid, and here you expect the gallbladder recurrence over 30 to 50% in 5 years. Larger the stones, observe symptomatically at therapy, and then if emergency surgery needs, do it. Moving on to third most common but less common than appendicitis and cholecystitis, acute pancreatitis. Again, patient experiences a sudden onset dull aching pain, a rapidly progressive pain, akin to epigastrium with radiation towards the back, usually refractory to all doses of analgesics. It improves with stooping forward. The study conducted by Batra et al. Showed about 84% of the study subjects had both amylase and lipase levels elevated, whereas selective raised lipase but normal amylase varies in 16% of cases. So here again, the raised amylase is specific for diagnosing the acute pancreatitis. USG helps to exclude the possible differential diagnosis to diagnose the gallstone pancreatitis, but doesn't establish the diagnosis. CT is reserved for the particular indications. Acute pancreatitis should always be diagnosed with both the clinical features and serum biochemical studies. A flowchart for the acute pancreatitis: a stable patient after resuscitation with the diagnosis of acute pancreatitis, do a CT scan. If there is a necrosis, conservative management, again for 14th day, antibiotics, TPN, if necessary, you can offer her that. Repeat CT after 14 days. If necrosis is seen and that is infected, treat it according to the culture sensitivity. If it's not infected, manage it conservatively. Again, repeat a CT scan after 14th day. If infection is still present, then do a necrosectomy. If infection is absent, then conservatively manage and necrosectomy if needed. I mean, if necrosis is absent, the conservatively managed patient goes home. The treatment initially should be managed conservatively with after resuscitation, preferably intensive care unit. The prognosis is assessed with Apache 2 or CT as a CT scan severity index. Necrosectomy can be done via the laparoscopic approach with an experienced hepatopancreaticobiliary surgeon. Now, the fourth one, most common thing is intestinal obstruction, which is usually characterized by colicky abdominal pain, vomiting, constipation, abdominal distension. Clinical presentation are often confusing since vomiting and constipation both can be present due to the physiological changes during pregnancy. Abdominal distension and visible peristalsis are difficult to assess because of the growing uterus. Unlikely the pregnant cases, there is no clear-cut protocol for investigations in these cases. Again, the most commonest cause for intestinal obstruction over here could be which warrants the surgery, strangulated, obstructed, and incarcerated hernias. Could be a ventral hernia, could be inguinal hernia, the femoral hernia, the hiatus hernia, in that case. The intestinal obstruction complicated as many as 1 in 1,500 to 3,000 pregnancies. They most often occur in third trimester because of the mechanical effect of rapidly growing uterus. Obstruction also occur in immediate postpartum period from the rapidly decreasing size of the uterus. So both the ways, rapidly growing uterus as well as rapidly decreasing size of the uterus. Amongst the patient bowel obstruction, the maternal mortality rate can be as high as 6% and the fetal mortality as high as 26%. This risk increases in the third trimester, where the maternity mortality rate can reach up 10 to 20%, especially if the diagnosis is delayed in treatment. Now, the incidence of bowel obstruction increases, it's increasing recently, perhaps because of an increase in number of abdominal procedures and increased incidence of PIDs. Again, both of them increase the risk of adhesions. And of course, last but not the least, increase in number of older women getting the pregnancy. Adhesions are thought to cause 60 to 70% of the small bowel obstruction during the pregnancy. Now here, the diagnosis of intestinal obstruction is challenging as the clinical symptoms mimic the morning sickness of the first trimester. Ideally, in pregnancy, MRI should be the investigation of choice. Again, the appendix, gallbladder, pancreatitis, intestinal obstruction, MRI. First sonography, then MRI, and then if not, the MRI is not available, then CT. Again, looking up after all the scenarios. If MRI is unavailable, X-ray abdomen can be done. Here, X-ray upright abdomen, it's something difficult. Get a supine X-ray done, which is better than the erect posture. However, the superimposed images of the fetal skeleton, the identification of dilated bowel loops can be difficult in the later stage of the pregnancy. Again, X-ray during the organogenesis should be done with caution. Decision should be taken after assessing the risk and benefit, explain well to the patient and the attending relatives. USG might show a hernia defect if an incarcerated hernia is suspected based on the physical examination or a patient history. The majority of other bowel obstruction improves with resuscitation, like hiatus hernia, give upright position and pantacids and everything, antacid can be given. If there is no improvement of such symptoms, then can be managed again successfully with laparoscopic technique rather than open surgical approach. Ultimately, evaluation by surgeon should not be delayed once the diagnosis is suspected. Sometimes the sigmoid volvulus, definitely the colonoscopy can identify the problem and treat the problem of the sigmoid volvulus. The surgery during the pregnancy for hernia is indicated only when the obstruction, strangulation, or incarceration of the hernia is suspected. The resection of the non-viable gut, followed by a stoma formation or a primary anastomosis, can be attempted if the bowel is gangrene or it's not viable at all. Now, to summarize and to discuss the non-obstetrical abdominal emergencies, any kind of pathology that can occur in pregnant women and require immediate surgical treatment and optimize interdisciplinary management to achieve maximum safety for both mother and fetus, to avoid teratogenous medication, fetal acidosis and hypoxemia, and adverse pregnancy outcomes such as miscarriage, stillbirth, or premature birth. It is possible maternal physiological changes during pregnancy, including gravid abdominal displacement of abdominal structures and respiratory changes, may increase the risk of perioperative complications. Despite the paucity of the data, there have been concerns that non-obstetric surgery may increase the risk of surgical, that is, maternal complications, as well as adverse obstetrical outcomes. A study of Fong et al. Focused on surgical interventions during the third trimester of pregnancy. Given the general recommendation, they should be avoided whenever possible. There are no clear recommendations as to the circumstances in which laparoscopy should be useful in pregnant women or open surgery preferred. A decision is mostly taken in surgeon's discretion. The pregnant woman had a higher risk of postoperative infection, septicemia, pneumonia, urinary tract infection, and in-hospital mortality compared with non-pregnant women. Pregnant women also had a longer hospital stays and a higher medical expenditures. The most common reported complications include the reoperation, about 3.6%, infection about 2%, wound morbidity, prolonged mechanical ventilation or reintubation, DVT, and death. There are no clear recommendations so as the circumstances in which laparoscopy should be used in pregnant women or open surgery is preferred. The decision is mostly taken by surgeon's discretion. Only for unclear acute abdomen with suspected acute appendicitis, Thus, the SAGES again guidelines recommends the laparoscopy again for gallbladder also. In a systemic review, the rate of elective termination of pregnancy following non-obstetric surgery was about 1.3%. The prematurity rate was about 8.2%. Fetal loss associated with appendectomy was 2.6%. However, the rate was increased when the peritonitis was present. The available evidence supporting the causal relationship between non-obstetric surgery and teratogenicity, preterm labor or delivery, or early pregnancy loss remains questionable. Therefore, withholding the indicated surgery during the pregnancy is not recommended by either an American Society of Anesthesiologists or an American College of Obstetrician and Gynecologists. Pregnancy does not increase the risk of post-operative complications after cholecystectomy or an appendectomy. ACUTE states, because of the difficulty in conducting the large-scale randomized clinical trials, in this population, pregnant population, there are no data to allow the specific recommendations. Hence, to conclude, when the need of non-obstetric surgery during the pregnancy arises, risk stratification, risk mitigation, and maternal counseling regarding anticipated outcomes can be challenging. The modern surgical and anesthesia techniques appear to diminish the rate of maternal death and neonatal morbidity. With the proper multidisciplinary approach, a non-obstetric surgery during the pregnancy should be considered to achieve maximum safety for both mother as well as fetus. Hence, to conclude, I would thank you all with a last quote. Something the questions are complicated and the answer very simple as put by Dr. Seuss. Thank you so much. Saurabh?
Thank you. Thank you, Doctor, for your wonderful presentation. And if you can close the slides, we can open the question answers round.
Yeah.
Thank you, sir. It was a wonderful presentation. I would like to invite the Dr. Kazi for your kind words. He's the president for CMAAO.
Thank you, Saurabh. Thank you, Avinash, for a wonderful presentation. And it was very nicely covered, the acute abdomen with the non-obstetrical or the acute abdomen with pregnancy. My question to you is that after doing any intervention for the non-obstetrical surgical procedure, do you think or do you have experience of putting the pregnant lady into labor, or you go for cesarean section?
Sir, like the thing is, we had come across some 3-4 cases, 2 cases of lap appendectomy, which I had performed in second trimester of the pregnancy. I mean, we got the appendix out. Patient eventually, after near reaching the date for expected date of pregnancy, she delivered with a C-section. But I had to do an perforated appendix, almost about to perforate the appendix. I had done successfully with the help of the lap appendectomy was done. The other few cases, what I had done external hemorrhoids, which were really big enough. Again, towards an end of the second trimester, we managed it nicely, and then she delivered eventually near to her expected date of delivery. Anesthesia techniques, the given form of anesthesia right now, it's something really good what we have on this side.
Okay, thank you. Thank you, Avinash. Yeah. It was wonderful.
Dr. Monica?
Thank you so much. That was a fantastic presentation, and it was a really nice summary of all, especially the acute abdomens in pregnant women at different stages of pregnancy. And what I really appreciated about what you said is to look at what the surgeon's level of comfort was, to be able to provide what form of surgical intervention. And when women come in for these acute emergencies, they don't know who they're going necessarily, and they might be seeing a surgeon they may not necessarily know. And I think for the best outcome for the For the mother, the best outcome for the fetus is to be able to identify what is the best route to make sure that they're all safe. So thank you for a wonderful presentation. I don't have any questions.
Sorry, my apologies from me and my Hinduja entire team, the IT team, the initial glitch about making my slides visible. And there's a technical fault at that place.
I think that's okay. We are living in a digital world, and I believe that we are dependent on technology. So where the human fails, technology takes over. Where technology fails, human take over.
Yeah.
So Dr. Elvin, I can see you. Do you have any questions? And Dr. Akhtar, do you have any questions? Okay, so before we were starting the session, I was talking about the COVID cases and during the pregnancy. Are you seeing any COVID cases at your level, and are you what special treatments are you giving them right now?
Over here in Mumbai?
Yeah.
See, first of all, my hospital, you don't admit any COVID patients. My hospital over here, there are two Hinduja hospitals. One is in Mahim and one is in Khar. So the place where I work, it's an, during the COVID duration, we used to not admit any of the COVID patients or COVID positive patients. The other branch, yes, my other colleagues had operated, few cases with COVID positive in pregnancy. One of my, again, the obstetrician, he had done, Dr. Nozer Shiriar, he had conducted more than, 100 deliveries during the COVID times. But not as a non-obstetric surgical emergencies.
So if your regular patient who is already having Hinduja as one of the hospitals for treating doctor, and if during that time the patient turns COVID, so you refer it to another hospital, or how does it work?
No. We don't refer it to another hospital. The other branch of the Hinduja, they have a dedicated COVID, had a dedicated COVID course. But last week we had some 3-4 positive patients of COVID.
Okay.
It's not that COVID is stopped completely, but we had 3-4 patients of COVID. They were here for elective surgery. Based on the symptoms, we carried on COVID test, and they turned out to be positive. We discharged her home, then we called her back for surgery.
So, Dr. Avinash, I think that's all for today.
Thank you so much, sir.
I really appreciate your efforts to come down during your working hours and give a presentation and enlightening us for the important topic. From the entire CMAAO team and the audience who are watching right now live, I would like to thank you for your time, and I would like to also invite you in one of the follow-up sessions later on.
Sure.
And thank you so much. I really appreciate your time.
Thank you so much. Thank you.
Bye-bye. So that's all. Yeah. Do you have any closing comments from your end?
This is the first experience for CMAAO, and yes, closing remark, the first and foremost is my apologies for all the things, mishaps on this side, and looking forward for some other good interaction with you all guys in near future with some different topics. We'll definitely look after it.
Thank you, Avinash. As Saurav very rightly pointed out, it's the technology error. You don't have to worry about that, but the main presentation was fantastic, and it went very smooth and very well. So we'll be seeing you again and again. And thank you, Saurav. Thank you, Monica. Thank you, Akhtar, and all others present on this platform. Thank you from on behalf of CMAAO. Thank you, everybody.
So thank you, everyone, for joining in. See you again on. We'll be meeting again on 15th of April for a next session. Till then, see you.